Thank you very much, Craig, and thanks everyone again for coming out. As Craig alluded to, I've been travelling around quite a bit, and I've given similar talks in various parts of the world, but a little bit more apprehensive because I'm a Sydney boy and this is a Sydney crowd, and it's always good to come home. And so I'd want to share with you some of our work that we've done at the University of Florida mainly, and how this research has influenced at least my perspective on the disease, which of course is extremely common. And just to also kind of give an overview, background, and my perspective on predominantly the mechanics of the disease. So yeah, as I said, as Craig said as well, I've spent the last 8 years of my career at the University of Florida. I feel very fortunate to have landed there, and we have a orthopedic lab where we conduct a lot of mechanical testing. And you'll see it's the comparative orthopedic lab, so we collaborate. It's a direct collaboration with the human medical school at the University of Florida, but we are also conducting a lot of clinical work in the newly built small animal hospital. So the title of this talk is Advancements or Advances in the Treatment of Cranial Cruciate Ligament Rupture. This talk is not, I wish it was, but it's not about new techniques. There are some on the horizon. This is an image from a brochure from out of the Kion group, who created the TTA, Tibial Tuberosity Advancement, and they're working on the holy grail of cranial cruciate ligament treatment, rupture treatment, and that is reconstructing the ACL itself. This is, I believe, near clinical release, but they have been working on it literally for the past 8-9 years, but still not available. This is not about regenerative techniques. At UF, we're actually conducting a prospective clinical trial on stem cell therapy for osteoarthritis. I can briefly mention that we conducted a pilot study in dogs with partial tears, hoping that these stem cells will heal the tear, and it does not. So we are still have a long way to go before we find biologic means of restoring the torn cruciate. There are some groups working on allografts. There's a group out of Michigan, actually not the vet school, the University of Michigan, and they're trying to come up with a bank of tendon treated in a certain way so that it's mechanically very strong, but very much in preclinical stages. This talk is not about prevention either, and this is a direction that I hope is expanded on, because I believe, and as you'll see potentially from the talk, once the cruciate is gone, as a lot of you probably appreciate, so much secondary change has gone on, it may actually be impossible to restore normal knee function. There are some groups working on identifying the potential immune mechanisms behind the condition. The latest clinical trial is they're looking for MHCs that are associated with cruciate rupture. There's some brilliant work that some of you might be familiar with, trying to associate certain morphologic features of stifles that could potentially predispose dogs to cranial cruciate ligament rupture. There are two schools of thought with regards to the pathogenesis of cranial cruciate ligament rupture. Those that believe that it's initiated by some sort of biologic event, biochemical event that degrades the ligament. These knees are arthritic, and then finally tears. There are others, and I'm in this camp, that believe that it is a mechanically driven disorder, that the cruciate is chronically stressed, gradually frays, then completely tears. Some of the morphologic studies have supported this theory. For instance, the greater the convexity of the proximal tibia, the greater the risk of cranial cruciate ligament rupture. Likewise, actually femoral neck anteversion, the greater the anteversion, the greater the risk of cranial cruciate ligament rupture. If you combine measuring anteversion with the tibial plateau angle, so quantifying the slope of the proximal tibia, actually can, to some degree, predict whether or not a dog will go on to develop cranial cruciate ligament rupture. And so perhaps we can try to breed this out of dogs. Breed the dogs that are morphologically not predisposed to rupture. But that's about all I have on prevention. This talk mainly revolves around refining and gaining a better understanding of the current treatment options. Specifically, I'll cover extracapsular repair, the TPLO, tibial plateau leveling osteotomy, the TTA, tibial tuberosity advancement. Not going to talk about this, but if I have time, I'll briefly mention the meniscus. It's a very controversial topic and takes up sessions in surgery meetings, but I'm happy to field any questions about the meniscus if any come up. Here's my take on the current understanding of the disease. And I'll use the analogy of a dog with, say, diarrhea. So you got this dog with diarrhea, and you put it on a special diet. You give it some medications, you give it some time, and then the dog responds. And you say, well, if somebody asks you, what was it that made the difference? And you might say, well, it was this pill right here, because this dog probably had some sort of bacterial overgrowth in the gut. This is an antibiotic. In theory, this corrected the problem. But you don't know if it was this. You don't know if it was one of these. You don't know if it was this. You don't know if the dog was always going to get better. And that's how I feel about cranial. That's my perspective on cranial cruciate ligament rupture. Because we don't only do one thing for the condition, do we? You tackle it on multiple angles. Even if you do surgery, most of the time they go home on analgesics, anti-inflammatories. There's a period of time of convalescence. So that pill that I showed, where you potentially thought was making the big difference, the equivalent is, for me, knee stability. So you presume that with surgery, you stabilize the joint. That's why they get better. That is absolutely not the case from our current understanding. Now, if we could get a stable joint, that's our ultimate goal. We're trying to restore normal mechanics. But clinically, that is not what we observe. And our research shows that you can have a persistently unstable joint and still have a clinically satisfactory outcome. This is a test that I like to do, and I like to check whether or not, even as a diagnostic, when the dogs come in, whether or not the dog is standing in subluxation. So I'll put my thumb on the fibella. I'll put my index finger kind of cupping the tibial tuberosity. And then I'll try to gauge if it is cranially subluxated. See that? You can click it back into reduction. So without draw, without thrust, the dog is naturally subluxated and you have your diagnosis. This is a dog after surgery. This is a dog that's clinically doing well. I don't have to tell you what surgery, because after TPLO, TTA, lateral suture, we've documented persistent subluxation despite good perceived clinical outcome in many dogs. So this was a clinical observation that actually Dan Lewis, one of the professors at UF that Craig had mentioned, taught me. He was like, see whether or not the procedure truly did what it was supposed to do. Check if they're standing in subluxation. And we did this, and the more I did this, the more we realized what's going on here. And so that was the main stimulus behind a lot of the studies that we conducted. Because we have theory, we have the theory of what we think's going on. We need to put some evidence behind that theory. And we've conducted some ex vivo studies, some cadaveric studies that I'll cover. We've conducted some in vivo studies where the dog's not moving. And we're in the middle of conducting some in vivo dynamic studies to see whether or not these procedures are truly doing what they said they were doing. I don't have much to present here because it's ongoing work, but hopefully it will be work that we'll be able to present and publish within the next year or two. The greater we head down this chain here, the more clinically applicable the results are. So there are so many limiting factors associated with trying to model what's going on in real life in a cadaver, and so on and so forth. So, but for the most part, until maybe early 2000s, everything was based off of just theory. So we'll just kind of cover the basic mechanics of cranial cruciate ligament rupture. This is stuff that a lot of you might already be very familiar with, so forgive me if it's a bit repetitious for you, but I'd like to cover at least a basic perspective on the condition that I really didn't have a great appreciation for until I really started to get interested in this. And one of the key points about knee mechanics is that it, as you all know, stifle is not a simple hinge joint. The knee doesn't flex about a single axis. This is a normal joint. Look at the amount of rotational laxity in a normal joint. This is what we actually should be aiming for, right? When we do our procedures. To be able to have that degree of laxity so the knee can function normally. This is called the screw home mechanism. On flexion, there is internal rotation of the tibia. Flexion, internal rotation of the tibia. Again, this is something that we should be aiming for. how often do we think about this when we're doing procedures in correcting cruciate deficient stifle? I don't think we are, particularly with regards to the current procedures that we're performing. This is a screen grab of some of the work that one of my residents is conducting, where we will take dogs and perform horizontal beam fluoroscopy. We'll get them to do all sorts of tricks. This is a dog that is sitting, and we were just amazed at the complexity of knee motion. I mean, look at that flexion. Look how far back the femur glides and rolls on that tibial plateau. Our procedures should really aim to restore this, and I firmly believe that the current procedures that we have now are still fairly distanced from the normal knee. Of course, the cranial cruciate ligament primarily stabilizes against cranial tibial translation, internal tibial rotation, and femorotibial hyperextension. We don't really have to go through this too much. There are some that think the disease is an immune-mediated process, hence the current studies, mainly out of Wisconsin actually, trying to identify a genetic basis for the condition, a genetic immune basis for the condition. You might find some reading where people believe that infection causes cranial cruciate ligament rupture. And the reason why is that a group conducted PCR analysis on synovial fluid, and they found bacterial DNA in synovial fluid. And so, well, here we go. There's bacteria in there. It must be some sort of bacterial infection. Subsequently, the same group, in collaboration with another group, followed up with another study where they had a control group of dogs with arthritis, but no cruciate rupture, and also found DNA fragments of bacteria. And it's just that they're floating in the bloodstream, occasionally get caught, not causing infection, but you'll find, if you look hard enough, bacterial fragments in some of these joints. So this theory has largely been disproven. It's progressive mechanical failure is what I believe it is. It's important to recognize that, as I'm sure most of you have seen, it's really a spectrum of disease. And they all start out, most likely, if we looked hard enough, as a partial tear. Gradually frays, use the analogy of a rope gradually tethering, and it can present to you as a partial tear because this can cause lameness. Even though the joint is stable, partial tearing itself and the OA that is associated with it will cause arthritis, so they can present to you with a stable knee. Partial tear can progress to a complete tear and present with an acute, actually quite a sloppy knee. Or the partial tear can very slowly progress, and there's enough time for periarticular change to occur. And for me, this is the most common presentation, kind of somewhat chronic complete tear. And actually all of these can lead to end-stage osteoarthritis. This is a fairly simplistic representation of the mechanics of the stifle that helps us understand how the TPLO works. And the theory that was brought about by Slocum was that if you sum up all the forces that are acting across the knee, the quadriceps, the hamstrings, and the gastroc, etc., the vector, the sum of all the forces, is approximately parallel with the long axis of the tibia. And this can be This is actually the sum of a joint compressive force, which is perpendicular to the tibial plateau here, and the resultant vector is this cranial tibial thrust. So because of this slope, and because the sum of the forces are not perpendicular, you have this cranial tibial thrust force. So every time the dog stands, the tibia wants to thrust forward and put stress on the ligament. And this is sort of fluoroscopic image, I think beautifully illustrates the reason why these dogs are lame. Here's the deficient stifle here. Boom, subluxation. I mean, quite massive instability. And this is fairly representative for most of the dogs that I see. Why is instability such a problem? One of the major reasons is, of course, that it crushes the medial meniscus and also creates a lot of degenerative joint disease. What we have with cruciate rupture, this is taken out of a osteoarthritis mechanics framework type paper from Stanford. This guy Andriaki is like the current god of OA, understanding osteoarthritis. So straight out of there, what we have with cruciate rupture is we have a shift in the contact regions of the cartilage, and this is, the joints do not like this. You get friction, wear, and cartilage breakdown. So we were particularly interested in how the joints are articulating with each other before and after cranial cruciate ligament rupture and before and after certain procedures to determine, well, do these procedures restore normal joint contact mechanics? And we have these sensors that we slide into the joint, and we can acquire this real-time data. These footprints here are actually representing the contact patterns within the joint. The blue areas indicate low pressures. The brighter the color, the higher the pressure. This is actually a normal stifle. Here's the medial compartment. Here's the lateral compartment. And as you could probably appreciate, they take on the footprint of the menisci. So there's a nice low, large contact area, uniform load transmission across the joint in a normal joint. This relies on numerous factors. It relies on a stable stifle, relies on minimal secondary degenerative change that occurred, relies on normal joint surface orientation, and relies on the presence of menisci. When the cranial cruciate ligament is gone, have a look at the pattern. You have subluxation, then the contact area markedly decreases. You can see just why the menisci get trashed, and focal very high pressures, 3 to 4-fold higher. So the aim of the procedure from a purest sort of mechanical standpoint is to get it back to that nice uniform load transmission across the joint. Otherwise, we have a problem because OA can continue to progress. Can we restore normal biomechanics? As a surgeon, this is our ultimate goal. So let's take a closer look at the extracapsular repair. How many of you guys are doing extracapsular repairs in here? Oh, a lot, okay. I do them too. I like it. I think it works. I'm bashing it here, but only to open your eyes to the mechanics of the procedure. Long-term stability relies on fibrosis. This is the key concept here, this concept of isometry, which I'm sure a lot of you are familiar with if you're performing the procedure. And that is, during range of motion, the distance between the 2 points that you choose to anchor your extracapsular repair should not change. If that changes, one of two things are either going to happen. the ligament's going to stretch or you're restricting range of motion. And in 3 dimensions, true isometry is impossible to achieve. Impossible. But there are better places where you can put it. This study, another Aussie, Simon Rowe, conducted quite a simple but elegant study where he picked a bunch of different points and a bunch of different points here on the femur as well, and checked the change in the distance upon flexion, and the higher you can get, the better for isometry. But all of them, you elongate on flexion. So what does this mean? You lose flexion with extracapsular repair. I'm sure a lot of you have appreciated that. Or if you regain that flexion, the suture stresses out. There are a plethora of new extracapsular methods that are out there, many involving bone tunnels to get to that better isometric point, such as the tightrope technique and anchor devices. But if you are positioning a suture outside the joint, no matter what points you are picking, it is very difficult or really impossible to achieve true isometry in 3 dimensions. Right, so remember that screw home mechanism, remember all that really wide range of motion of the stifle, remember that rotational laxity that's normal, gone with the extracapsular repair. With the extracapsular repair, because the points are outside the joint, we're fixing the stifle in external rotation. We're fixing it in mild abduction, and you're limiting flexion. And this was shown in a nice study out of Canada, actually. Just a cadaveric study, but a lot of very useful information came out of it. We simulated a dog running for several meters with lateral suture using nylon leader line, and they all stretched out. They all stretched out. And this is my clinical impression too. Here's a dog that had a lateral suture. You can see the thrust. And I firmly believe, unless my teachers were just very poor teachers and I'm performing the technique poorly and all my colleagues are performing the technique poorly, that if you look hard enough, you will find this in many of the dogs that have extracapsular repair. Just by pure mechanics. It's not unexpected. The other problem with the lateral suture is that we are altering the distribution of forces, the balance of forces across the medial and lateral compartments. And we did a study where we slid this sensor in under the menisci, the lateral compartment, and found that if you apply a lot of tension to this suture, what do we see? We see high compartment pressures laterally. Here's a post-mortem specimen that corroborates our findings. We have full thickness wear in the lateral compartment. So we concluded, again, based on the cadaveric studies with multiple limitations, but if you really crank on that suture, and I was taught by one of my advisors to tighten it as tight as you can get it in a medium to large breed dog, that we're squishing this lateral compartment here and the joints are not happy. My view on the lateral suture, now all of what I had mentioned flies in the face of what we clinically see, isn't it? Like a lot of them do really well. But based on my clinical observations, based on the research that we've done, and based on some of the newer papers that are coming out, I am very reluctant to do it in a dog that has a high level of activity. And the larger the dog, the greater the forces, probably the greater the reliance on normal mechanics. So the larger the dog, the less I am excited about the lateral suture. I still do them. They are in our hospital less than half the cost of a tibial osteotomy. And sometimes our hands are tied. Yeah, very athletic dog. And I will actually, I've gone to coapting my lateral sutures for a while. Rightly or wrongly, I don't know. But I feel that on flexion, right, they're stretching that ligament. So I've stopped having my owners do aggressive range of motion therapy after lateral sutures. And I'll fix them in a standing angle with a soft padded bandage. This is a semi-rigid splint for around 3 weeks or so, at least to help that initial fibrosis to develop. And remember isometric points. If in doubt, especially if you're starting these, and it sounds like a lot of you are quite experienced with it, but I find, at least when I was starting them, it really helps to shoot a radiograph to see that your tunnel is where you thought it was going to be. A lot of these studies are beautiful studies, prospective, elegant studies, comparing lateral suture to mainly TPLO, but one here to TTA. No, actually it's not here. Mainly to TPLO, but a lot of the earliest studies, actually all of these, could not find a difference between the outcomes following lateral suture and TPLO. The last 2 years, 2 larger, even more elegant, well-refined studies have shown that TPLO is consistently superior to lateral suture. There's still not a lot of work on the TTA. It's lagging a little bit because, of course, it's a slightly newer procedure. So this novel concept of changing the shape of the proximal tibia so that the stifle does not need the cranial cruciate ligament anymore has, to a large extent, really revolutionized how we treat this condition now. Cranial closing wedge, osteotomy, TPLO, TTA, of course. So a little bit on the mechanics of these. Plateau leveling, if you remember this diagram, it's a little confusing, but if you can make the slope here, this downward slope of the tibia, more or less perpendicular to the tibial axis, then your joint reaction force is parallel with the joint compression force, and you eliminate cranial tibial thrust. That's the basic premise behind the TPLO. Slobodan Tepic, the guy who invented the TTA, said that you've got it all wrong, Slocum. You are viewing this a little too simplistically. And he proposed, based on some theoretical modelling, that if you sum up all the forces acting across the knee, the stifle, in dogs during most activities, it roughly actually parallels the orientation of the patellar tendon. And so now, if you can get the patellar tendon perpendicular to the plateau or the tangent across the joint, you eliminate cranial tibial thrust. So kind of a bit difficult to explain to owners, but more or less we're reorienting the patellar tendon alignment so that the quadriceps is less inclined to pull the tibia forward and more inclined to push the tibia back. So if you flex the knee, you will make the patellar tendon perpendicular and then even acutely angled relative to the plateau. So in flexion, the knee does not rely, the stifle does not rely on the intact cranial cruciate ligament. And we demonstrated this with a cadaver study, and it is also kind of the theory behind the cranial closing wedge osteotomy. Put the knee into more flexion. TTA, of course, most of you are familiar with. Excellent outcomes have been reported so far. It really is gaining popularity. Based on my short relatively short time here at North Shore and understanding sort of the common procedures that are performed in and around Sydney, I was somewhat surprised to see just how popular the TTA was. I thought it still was going to take a little longer for it to catch on. There are multiple systems available, but Kion system is the one that was originally created. So again, we're not relying on any passive structure. This is dynamically stabilizing the joint. We need to cut the bone, which is intimidating for a lot of owners, and it requires a lot of specialized equipment and big investment if you want to start performing this. And also they're expensive to the owners, as I mentioned before, over double the cost of a lateral suture at our institution. And on top of this, we don't really truly understand if there are any detrimental effects to the procedure. So remember this whole concept of trying to restore normal contact mechanics? Well, the TPLO may actually alter normal contact mechanics. Why do we suspect this? Well, several studies have shown that osteoarthritis almost invariably progresses after the TPLO. And anecdotally, and actually in one recently published studies, people have discovered these like focal cartilage defects in the stifle after TPLO. There's an equivalent procedure in humans called the high tibial osteotomy, and they will alter the angle in the coronal plane. So for a varus knee, they'll create valgus. But if they screw it up and they don't keep in mind the sagittal plane orientation, then they're altering the contact stress distribution, in this case more posteriorly. And this study concluded, hey, if you're not mindful of how you're altering the slope with the high tibial osteotomy in people, you could be doing this, and this is bad because you're altering the mechanics in such a way that is further away from normal. And that's what the TPLO does, doesn't it? We're altering the orientation of the cartilage surfaces. So with this in vitro modeling, we in half of the dogs, we performed a TPLO, cut the cruciate, performed a TPLO, and then in the other side, actually the left side versus the right side, the other side we did a TTA. Now the y-axis here represents the contact area across the joint, and in basic terms, the higher the better, right? The larger the area of the contact, the better. We see a marked decrease in the contact area after you cut the cranial cruciate ligament. And then we perform the TPLO, and you can see the contact area is better, but it was still significantly smaller than normal. However, after the TTA, it actually restored normal contact area to the point where we could not find a difference from normal. Here's an illustration of how the TPLO alters the pressure distribution across the joint as well. And where we're trying to look at where the highest point of pressure is across the joint. In the normal joint, it's kind of smack bang right in the middle of the joint. And then you cut the cranial cruciate ligament, we have cranial tibial subluxation, and the peak pressure is now really caudal on the tibial plateau. And then we perform the TPLO, and it cranially shifts that contact pressure, but it's still significantly more caudal than normal. Whereas you perform the TTA, despite the same pattern of shift with cranial cruciate ligament rupture, it did restore the peak pressure location to normal. So that we concluded that the TTA had a better potential ability to restore normal joint contact mechanics when compared to the TPLO. This is an illustration of what we think's going on We almost have what we call like a nutcracker effect, where we're impinging the caudal aspect of the joint. So we're caudally distributing the pressures focally in a more convex area of the femoral condyle. And potentially one reason why OA is persisting or progressing following TPLO. Now, everything that I just gone through in terms of the mechanical study, take with a grain of salt, because there are a lot of assumptions, and how clinically relevant these shifts are is really actually unknown. What does it truly matter that the peak pressure location shifted by 3 millimeters? We don't know. What is truly important is what is going on in the live dog. So that's what we've moved to, live dog studies. We've conducted and subsequently published 2 in vivo studies on femorotibial joint alignment following TPLO and TTA. We exposed a bunch of vet students to some radiation, had dogs with cranial cruciate ligament rupture standing as naturally as possible, and stuck a cassette between their legs and shot a horizontal beam radiograph. So we'll get an image like this, and so we're trying to work out what is the joint doing when they're naturally standing. We came up, well actually we didn't come up with this, we found it somewhere, but we somewhat validated it. To work out if a joint is in subluxation or not, we measured the distance between the origin and insertion of the cranial cruciate ligament. And so if this distance increases, then we have subluxation. So that's what we did. This is results for the TTA. And this column represents the cruciate ligament distance when the dog was not bearing any weight and it was immediately post-surgical. So we're presuming this is not subluxated, right? So the distance of about 26 millimeters. We brought them back for a follow-up ranging from about 6 months all the way out to 4 years, and had them do this weight-bearing radiograph. And you can see that the distance was significantly longer than when compared to if they were non-weight bearing. So they were actually statistically significantly subluxated after TTA. But it is only in the order of around 3 to 4 millimeters. But, you know, in the ideal scenario, we would hope that it's down here, wouldn't we? And over 90% of dogs clinically do very well with TTA. So why is there this discrepancy? We've stabilized the joint. It should be down here, shouldn't it? So this was kind of a surprising finding for us. Here's some representative radiographs. This is a dog that is not subluxated. Here's the immediate post-op. Let's draw a line down the caudal aspect of the femoral condyle and the tibial condyle. Right, normal alignment. Here's a dog weight bearing several months after TTA, and the joint is not subluxated. Here's another dog clinically doing just fine. Owner's very happy with the outcome. Immediate post-op, not subluxated. Look at this. Dog is weight bearing. You see the femoral condyle slipped off the back of the tibial condyles. This dog is subluxated. So the TTA right there is not really doing its job, is it? Well, how about the TPLO? Here's a subluxated joint. After TPLO, same dog. The joint is much better. But a third of dogs following TPLO did this. 1 in 3. I was shocked. Look at the subluxation here, despite the dogs clinically doing well. So clearly, the ability to eliminate subluxation doesn't directly correlate with limb function. Why are these dogs subluxating after surgery? I I didn't present some of the data, some of the other data we collected in that cadaveric study, but we also were able to measure the positions of the bones. And after TPLO and TTA in the cadaver, the joints were stable. So why are we seeing this discrepancy here where in the live dog, in clinical cases, some of these dogs are not stable? Because it's complex and there are so many other factors going on. One theory, at least the TTA, and as we've refined the procedure, I think we're getting better at stabilizing the joints more efficiently, more successfully, is that perhaps we're under-correcting. So perhaps with a TTA, at least for a lot of those dogs that we did, we may not have advanced far enough. I help teach the Kion course for the TTA. I've been helping them over the last 5 years, and at each course, well, there's been this push towards moving to a larger cage size, to what we used to advocate. So I think we can get better at this by modifying technical recommendations. Perhaps there's a poor balance of muscle forces. Remember that whether or not the tibia goes this way or this way is dependent on the balance of the pull of the muscles. And so the further away we drift from normal balance of muscle forces, I think the further away we drift from the theory, and so we're not getting what we think we're getting. Maybe the remedy to this is to get more aggressive with rehabilitation. And certainly we're appreciating the great importance post-operative rehab is in the clinical outcome of these dogs. Perhaps the meniscus actually plays an important role in achieving stability. I won't go into this too much unless any of you want to particularly see the data, but we found that in dogs generally that had meniscus taken out from a meniscal tear, those joints tended to be subluxated more frequently than not. So maybe we need to be better at trying to preserve meniscal function. And some of these joints are really sloppy, and I think it's sometimes foolish to expect in very, very lax knees that these dynamic procedures are really going to restore stability. So at least from my perspective, I will try to do some sort of an imbrication, sometimes even combine it with a gentle lateral suture when I'm performing a TPLO or a TTA. We are conducting some dynamic studies. Here's a C-arm that cardiology use, but we're kind of using it, we've sabotaged it, we're using it a bit more frequently now. To work out what's going on with the joints when they're moving. Here's an example. That's kind of a small image. Here's the dog subluxating. The two procedures we're studying right now are the lateral suture and the TPLO, and we're hoping to start to investigate the TTA in the next year or so. Here's the dog after TPLO. This dog's doing well, and the joint is actually looking quite happy, no subluxation. Why are we doing all of this, putting these poor dogs through these machines and exposing them to radiation and trying to understand what's going on, even though clinically we have a greater than 90% success rate? The more you look, the more you find. And I think the more we look, the better we can refine techniques. We have a better ability to compare different procedures. Perhaps we can really tailor the treatment according to the individual dog through this knowledge. And ultimately, from someone that has a particular research interest in this, we're finding so many flaws with all of the procedures that we're currently doing, and at least to drive us into a direction for a better technique. Maybe in 20 years' time we'll look back and think, what the hell were we doing cutting those bones? And putting them through all of that surgery. So in summary, there's no perfect procedure. We do have a limited understanding of the disease and the treatment. I firmly believe that refining and developing treatment options should be based on both clinical experience and scientific research. And that's all I have for you. This is the hospital that I work at. It was finished 2 years ago. It's a $60 million facility. It is just massive. I feel very fortunate to work there for sure, but I do miss home incredibly, and I'd come back here in a heartbeat if I could. Okay, cheers, thank you.